Welcome to AETCM, the emergency medicine channel. Now let us discuss about septic arthritis or bacterial arthritis. Acute septic arthritis or infectious arthritis or suppurative arthritis is a joint infection which is invasive of a joint by an infective agent like bacteria, resulting in joint inflammation, destruction. All complications can occur. Normally, septic arthritis involves only a single joint. Rarely, multiple joints can be involved. Most of the patients can have high degree fever, weakness, headache. Like any other infection, patient can have a lot of other clinical findings that can also be seen in septic arthritis. In adult, it may produce joint inflammation and rarely joint damage. But in children, since it's a growing age of the bones and joints, it can produce serious consequences if not treated properly. The most common organisms which can produce septic arthritis is gram-positive cocci, streptococcus and staphylococcus. Gram-negative bacilli can present with joint involvement, especially in diabetic patient, immunocompromised patient, previously damaged joints. Brucellosis is one condition not very common in our country, but that can present with involvement of joint diseases. Staphylococcus aureus, sometimes it can become methicillin resistant Staphylococcus aureus, that is MRSA. Here many antibiotics are resistant, so that can also occur. Most of the septic arthritis are monomicrobial. That means only single organism will be responsible for the joint involvement. Polymicrobial infections are not very common, but in patients who is having trauma, especially penetrating trauma to the joint, can sometimes present with polymicrobial infection, and hematogenous spreading also can present with polymicrobial infection. Now, if you see the presentation of septic arthritis, severe joint pain, swelling, redness, effusion, high degree fever, features of sepsis, all these things can be there. Most of the time, knee joint is the commonest joint which will be involved in septic arthritis. Polyarticular involvement can be there in systemic diseases like rheumatoid arthritis or other connective tissue disorders. These are the risk factors for joint infections, septic arthritis, like infection from skin, previous intra-articular injections, prosthetic joints, joint surgeries, diabetes, HIV, previous osteoarthritis, rheumatoid arthritis, gonococcal infections, that's a sexually transmitted disease, age more than 80 years, that is also another risk factor. So these are the common risk factors, but clinically most important thing is one is previous joint damage and joint surgeries. These are the two important things can present with infections. And like any other disease, diabetes is one of the major risk factor for all types of infections, including septic arthritis. Now, when we have a patient who is having joint effusion, joint swelling, suspected joint infection, we always try to tap the fluid from the synovium. We see the cells in that joint fluid. In bacterial infections of synovium or septic arthritis, the counts are very, very high. It will be more than 50,000, 25,000 to 2,50,000 is a normal range. or normal range in septic arthritis. Most of the time it will be more than 50,000. Culture of this joint fluid will be 90% positivity. Gram stain can be 50% positivity. Gram stain, one advantage is immediately after the joint aspiration we can do and find out whether it's a gram positive or gram negative bacteria. Culture takes some time. Mostly it takes 48 to 72 hours. Blood culture positivity can be observed in 50% of the cases. X-ray joint can be done. It shows joint diffusion, osteomyelitis, bone erosions. All these things can be observed in X-ray joint. Complete blood counts, mostly it will be elevated. WBC count will be elevated. CRP will be elevated. ESR will be elevated. Uric acid can be elevated in gouty arthritis. That's a close mimicker of septic arthritis. Patients have all features of septic arthritis, joint diffusion, pain, tenderness, redness, everything. But it commonly occurs in the first metatarsophalangeal joints. Septic arthritis commonly occurring in the knee joint, but both can occur in any other joints also. So this is a chart which will tell you what will be the synovial fluid examination findings in various types of arthritis. Septic arthritis, we have already told, WBC counts are very high, more than 50,000. Predominantly they are neutrophils. Viscosity is low, cloudy yellow. Then we can ask for gram stain and culture. Now, commonest organism and commonest presentation, we already discussed, it's Staphylococcus and Streptococcus. Staphylococcus, healthy patients, skin injury, previously damaged joints, like rheumatoid joint, prosthetic joints, all these things, Staphylococcus is common. Streptococcus, classically occurring in a normal individual, associated with tenosynovitis, tenderness surrounding the joint, vesicular pustules, negative synovial fluid culture and gram stain can be seen in streptococcal infection. Aerobic gram-negative bacteria, immunocompromised host, gastrointestinal infection. Anaerobic gram-negative bacteria, immunocompromised host. Brucellosis, exposure to animals can be, especially cattle, can be there in that type of patients. TB, fever, weight loss is a common finding. Fungal infections, immunocompromised patient. Spirochetes like Borrelia. It's not very common in India. Exposure to ticks. Rash will be there. Knee joint involvement will be there. Mycoplasma, again immunocompromised host. Another important infection can present with septic arthritis is gonococcus, Neisseria gonorrhea. It's a sexually transmitted disease. There are two important types of gonorrheal joint involvement: disseminated gonococcal infection and gonococcal septic arthritis. Gonococcal septic arthritis mainly involves a single joint like hip, knee, ankle, wrist. Disseminated gonococcal infection, fever, chills, rashes, papules, pustules over trunk and extremities. Migratory arthritis, they are not a septic arthritis. It occurs due to immune complex deposition. Gonococcal septic arthritis, the main feature will be the counts will be more than 50,000 cells per ml. But normal gonococcal arthritis, that is disseminated gonococcal infection, it will be slightly higher than normal, 10,000 to 20,000. So both possibilities are there in gonococcal infection. It can be either immune mediated reaction or direct invasion of organism into the knee joint. Now TB can also present with septic arthritis, not very common, but it can also present. Generally the infection part, that is joint, will be cold, like cold abscess. So there will not be any signs of infection or inflammation in the joint. There will be joint effusion, but these things are not very common. Granulomatous changes with synovial proliferation is seen in tubercular arthritis. Joint effusion and erosions of cartilage can occur. Another type of joint inflammation as a part of infection is reactive arthritis. That means infection somewhere in the body that triggers a problem in the joints. One of the classical presentation is Reiter syndrome. Here the patient can have arthritis, urethritis and conjunctivitis. Another important type of reactive arthritis is Ponset disease. It is due to tuberculosis. Tuberculosis can patient can have TB somewhere else like lungs or lymph nodes, but patient will have lower limb arthritis, especially asymmetrical lower limb arthritis with spine involvement. That is Ponset disease. Now, those who are having prosthetic infections, prosthetic joint infections, they can present mainly three categories of prosthetic joint infections. One is within 3 months of implantation. Next one is later than 24 months, after like 3 to 24 months, then after 24 months. Most of the cases of early prosthetic joint infections are due to Staphylococcus aureus, especially MRSA. The 3 to 24 month group are usually caused by coagulous negative Staphylococcus aureus or gram negative aerobes, both of which are occurred in the operating room. So remember, all these hospital acquired infections are multi-drug resistant or MRSAs in the joint. Late causes for prosthetic joint infections are secondary to hematogenous spread from variety of infectious foci. So according to the time of infection, there are three important types. So according to that, organism also can be different. Now, empirical antibiotics are very important in septic arthritis in emergency room. So if the initial gram stain of the synovial fluid shows gram positive cocci, then vancomycin should be started. 30 mg per kg per 24 hours in 2 equal divided doses. So you can give 15 mg per kg morning, 15 mg per kg evening. If the initial gram stain shows gram negative bacilli, we can start ceftriaxone or cefotaxime or ceftazidime. But most of the time these facilities may not be available in our routine practice. So whenever we have an infection, suspected infection, we know that it can be either gram positive or gram negative. Most of the time it is gram positive. So in emergency room we have to cover both the infection, both gram positive and gram negative, before we getting a culture report or gram stain report. So we can combine these two drugs. Vancomycin with ceftriaxone will be a very good choice in emergency room when the patient come with septic arthritis before getting any report, because whether it is a adult or child, if we don't treat if we don't treat from emergency room itself, patient can have serious complication like joint destruction and permanent joint damage. So antibiotics should be initiated immediately from ER itself. Now duration, if we see, in uncomplicated septic arthritis, antibiotics 2 weeks. Initially we can give IV antibiotics, then if patient is stable we can switch to oral drugs. Septic arthritis with osteomyelitis, antibiotics for 3 weeks. MRSA we have to give 3 to 4 weeks. So these are the durations of antibiotics to be given in septic arthritis. So we have discussed about septic arthritis, various causes like gram positive cocci and gram negative bacteria. Synovial fluid cells like more than 50,000 cells or gram stain or culture reports can give you the clue about the possible infection or possible type of infection. Past history of joint inflammation, joint infection, or immunocompromised status. All these things are very important in patients who is having septic arthritis. In emergency room, we have to start empirical therapy with both gram positive and gram negative coverage. Ideal combination will be vancomycin with ceftriaxone. Once we get the organism in culture, we can change according to the culture report. The antibiotic should be continued for 3 to 4 weeks. Thank you.